Oops. So this is the link and this is the code. I see here just 2 people and there's 19 people, so we need to have all those 19 people here. If you have typed the code on the link, just type this so I can see you. And of course, I need to remind you that the voting in this app is anonymous, so I can't see what you're voting. You can feel free to vote whatever you want, choose the answer that you want, and nobody will see it. Mm. 6. We're at 6. Okay. So as I've told you, enter menti.com and then the code. So let's begin. You will see this all the way. So if you log out or something like this, you can just type again the link and then the code. We'll begin our presentation. Here is you can just type the answer and it will look in a diagonal and messy way. It's just like a test, because after that you will be having a real question and you need to type other answers. Okay, happy that you're all feeling good and great. Yeah, same. I'm feeling a little bit tired, but it's okay. It's all about commitment. We don't need to have motivations all the time. That's good. Let's do our best then. After this, it's a little introduction about me. I think those who have seen my first presentation know that. So I'm 7th year medical student. I really want to teach other and hear what other teach to make each other better. I have a little bit of certificates and accomplishments. I'm a member at the Association Les Randonneurs and a former president of the Office of Sports, Arts and Associations at my university. I have several certificates that I've done online. So I have it from Harvard and Imperial College of London. And I've participated in several conferences like the breast imaging interventional workshops. So let's begin with an icebreaker. Something that can travel around your body without moving. It's invisible, but reveals what's hidden. What am I? So here you can type your answers. It's related to radiology, so take some guesses. RX. What else? X-ray. What else? Nice. We're having a lot of responses. X-ray, rains, air. That's good. That's some good guesses. Okay, let's see what's the answer. You guessed the answer. Yeah, it's X-ray. Okay, so our objectives of today. First, we will try to differentiate between various causes of acute abdominal pain using radiological evidence. Second, we will try to identify the appropriate imaging modalities for common and rare abdominal pathologies. And third, we'll try to interpret radiological findings to guide clinical management and avoid unnecessary interventions. And of course, we will have three take-home messages because we will have three cases and a last take-home message. So let's begin with our first case. So the first case is about a 43 years old patient presenting with sudden onset of left flank pain radiating to the epislateral iliac fossa and external genitalia. So I'll repeat for those who didn't hear it. It's a 43-year-old patient presenting with sudden onset of left flank pain radiating to the epislateral iliac fossa and external genitalia. That's good. For those who's watching this and want to participate in this vote, they can just type this link on their phone and then type the code. That's good. So what is the most common etiology for acute renal colic? Is it ureteral tumor, renal tumor, ureteral calculus, or urinary tract infection? Oh my god, this word. Yes. Yes, it's the third one. This one. Ureteral calculus. After that, what is the appropriate initial radiological investigation for acute renal colic? Is it plain abdominal X-ray? Plain abdominal X-ray, it's ASP that you know. Or ultrasonography, or non-contrast enhanced computed tomography scan, scanner. Contrast enhanced CT scan, or intravenous urography. The third one, c'est non contrast, it's c'est moins. Sans produit de contraste. And the fourth is with the contrast. Mm-hmm. Okay, should I say what is the right answer? The right answer is the least voted one. It's the non-contrast enhanced CT scan. But that's good. That's good. We are here to learn. So this is the CT scan. It's an abdominal pelvic CT scan without contrast in axial slices. This is the axial slices. And coronal and sagittal reconstructions, because those are the reconstructions. So you can see those. Because I will ask you after that which finding is not visible on this CT scan. So I'll tell you what is the question, and then you can see the image and then vote. So the question is, which finding is not visible on the CT? So is it dilatation of the left ureteropedicalicial system, thinning of the left renal parenchyma, infiltration of the perirenal and periureteral fat, calculus in the lumbar ureter? Mm-hmm. As I told you, you can vote whatever you want. We are here to learn. And for those who wanna vote, they can just type this on their phone and then type the code. That's good. Mm. The right answer is the one having four. The one that has the four votings is the thinning of the left renal parenchyma. So we can see here in the image, we have the calculus, as you can see, in the coronal and axial slides. And there is you can see the left pielocalicial dilatation. And there is the infiltration. Infiltration, you can see it around the renal parenchyma. You can see this is the infiltration. I don't know if you can see that. This is the infiltration. So the only thing that we can see here is the thinning of the left renal parenchyma. And just so that you can understand, the thinning of the left renal parenchyma doesn't happen at the acute stage, because the thinning of parenchyma will result of the dilatation of the left ureteropielocalicial system. So if it dilates more, it can just press into the renal parenchyma and then it can result on its thinning. Now we can see this. So the interpretation of this CT scan is a moderate dilatation of the left ureteropielocalicial system with infiltration of the perirenal and periureteral fat upstream of lumbar ureteral calculus, measuring 4.5 with an estimated density of 655 house-filled units located at the level of the L4 vertebral body. But if you can see the calculus and the left spinacal, that's good. That's all you need. So now we will see a multiplanar reconstruction demonstrating the calculus. I don't know if you've seen this before, but this is the reconstruction. Okay, let's continue. Additionally, we have a medium-sized 6 millimeter calcial stone in the right kidney, estimated density of 400. It's here, as you can see. This is the calculus. And it's the right kidney. So one take-home message, the first take-home message of this first case is the non-construct enhanced CT scan of the abdominal and pelvis is the first line diagnostic modality in cases of acute renal colic. So if you suspect the acute renal colic, the non-contrast enhanced CT scan is used in the first line. So what it can show us? It can show us the location of the calculus, its size, its density, and it can show us the upstream effects, the dilatation of the excretory pathways, the infiltration of the perirenal fat, and it can also show us the presence of any additional stones, as we've seen in the previous slide. Now we have our second case. So the second case is a 33-year-old female patient present with pain in the right hypochondrium and tenderness on clinical examination. So this is an AI pic. It presented the case in a really good way. So you can read the case again, because we will have several questions about this case. So the important things here is the age, 33 years old female, the pain in the right hypochondrium, and the tenderness in the clinical examination. Let's go straight to the questions. What examination should be requested? Is it abdominal ultrasound, intravenous radiography, plain abdominal X-ray, or none of the above? Just vote whatever you want. Good. So everybody told us it's abdominal ultrasound. Yeah, you're right. It's abdominal ultrasound. So this is the abdominal ultrasound. As you can see, I don't know if you can see the kidney and the other structures, but it's okay. We'll go through this. This is a second pic of the abdominal ultrasounds. This is a typical image, a really typical image. So just try to remember this image, because you have now to guess the diagnosis that you will be suspecting. What diagnosis do you consider? Is it gallstone disease? Is it hydatid cyst? Is it hepatic tumor? Or none of the above? For those who log out or something like this, or just are not here with us in this app to vote, they can just enter to menti.com and then type the code. Yeah, that's good. Well, the right answer is hydatid cyst. We will see why. That's okay if you guessed it wrong. That's okay. The right answer is hydatid cyst. We will see why. So this is the abdominal ultrasound, and as you can see, this is a typical image of the hydatid cyst. It's showing a multivesicular hydatid cyst. I don't know if you can see the vesicles, but this is what it looks like, having a multivesicular hydatid cyst. So in this pic, you can see it more clearly. What additional examination do you request? Abdominal CT scan, abdominal MRI, no further examination, or plain abdominal X-ray? Mm-hmm. Now you did your ultrasound, you found a multivesicular hydatid cyst. So now what will you do as a doctor who have this patient? Okay. We will see what we will do and why. So we will do an abdominal CT scan, and we'll do it so that it can show us more details. So this is before contrast injection. We can see a parietal calcification. And this is after contrast injection. So here we can see the multivesicular edated cyst. We can see that it's in contact with the colon and the kidney. So the second take-home message is that the CT scan allows us to look for other locations, search for signs of superinfection, and assess the anatomical relationships with adjacent organs. As you can see, the CT scan showed us that the multivesicular edated cyst was in contact with the colon and kidney, and doing the injecting the contrasts helps us in seeing if the edated cyst will take the product and shows as a white structure or just remain the same. And as you could see, it remained the same. This is before and this is after. So that confirm that it is an edated cyst. And here we can see what organs come in contact with our edated cyst. Okay, so you can screenshot this take-home message if you want, or if you just know it, you can skip it. So I hope you're feeling like a medical Sherlock. We have a third case, an interesting third case. So I hope you have some energy remaining to keep up with us. So this is the third case. Our third case is a 70 years old diabetic patient presents with acute pain in the right iliac fossa without fever. The laboratory workshop shows us white blood cells that are normal and elevated CRP. So the important things here is the age. We have 70 years old and it's a diabetic patient. He has acute pain in the right iliac fossa. He doesn't have a fever, but randomly he has an elevated CRP. And the white blood cells are normal. So let's see what is the first question. The first question is about diagnosis. So which diagnosis should not be primarily considered? I'm not telling you to choose what this patient have. I'm telling you to eliminate one diagnosis. You can eliminate it by looking at the location, because the location of the pain is the right iliac fossa. Think of the organs that are in the right iliac fossa, and then you can guess what you can eliminate. Mm-hmm. The right answer is gallbladder stones. The gallbladder stones. This is the right answer. This is the answer that we should eliminate. Because if it's gallbladder stones, he will have the pain not in the right iliac fossa. He will have it as our first case. He'll have it in the left flank. Okay. Given this clinical picture, which radiological examination would you perform first? So our patient is having an acute pain in the right iliac fossa. He doesn't have a fever. He has an elevated CRP. So what are you doing now? Will you do an abdominal ultrasound? Will you do an abdominal CT? Will you do an abdominal MRI or just plain abdominal X-ray. Okay, everyone is saying abdominal ultrasound. Well, you're right. The abdominal ultrasound is normal. What would be your next step? So you did your ultrasound and it's normal. What will you do? Will you perform an abdominal pelvic CT scan, perform an abdominal pelvic MRI, discontinue further exploration, or perform a control ultrasound? Yes, this is the correct answer. It's perform an abdominal pelvic CT scan. So this is the CT scan that you wanted to perform. This is a CT scan before and after contrast injection. So I guess you can see all the structures here. So what abnormalities do you see on the CT scan? Do you see an infiltration of the pericervical fat, an enlargement of the appendix, a thickening of the digestive tract wall, or ureteral stone? Here you can choose your answer. For those who want to vote with the others, they can just type menti.com and then type the code. Mm-hmm. Mm-hmm. Yes, this is the right answer. It's the infiltration of the pericycle fats. So this is the CT scan before and after contrast injection. It's showing us the infiltration of the pericycle fats. We don't have a digestive tract thickening, and we have a normal looking appendix, as you can see. I don't know if you can see the continuity of it, but this is the colon and this is the appendix, and it's normal. It's not thick. What is your diagnosis? Is it appendicitis or sigmoid diverticulitis or colitis or other? Mm-hmm. 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 So now let's see the correct answer. So some voted for others, some voted for sigmoid diverticulitis, and some voted for the colitis. Where unfortunately it's another one. It's no, it's the it's not an appendicitis, it's not a sigmoid diverticulitis, and it's not a colitis. This is the CT scan before and after contrast injection. We can see a novel formation, juxta and lateral of the cecum of fatty density, outlined by a fine band. Well, as you can see here, this is the fine brand, like this, and enhanced after injection, measuring 22 millimeter with central hyperdensity in the arrowhead. You can see the arrowhead here, right here, and it's right in the central hyperdensity. There's a central hyperdensity and then a novel formation. I hope you can see it. Okay, we'll go to the next slide. It's an epiploic appendagitis. It's a diagnosis that not a lot of people think of, but it's important to think of it, especially in the older patients, because our patients have 70 years old, 70-year-old, so we have to think of it. So what is an epiploic appendages? Epiploic appendages are fatty formations along the colonical tinea from the cecum to the sigmoid. So that, as you can see in the pic, is the epiploic appendages. And what is an epiploic appendagitis? The definition is the inflammation of the epiploic appendage due to the torsion or spontaneously by thrombosis of its draining vein. Yeah, so it's the inflammation of these epiploic appendages. That's what our patients have. It can mimic the sign of the appendicit. The take-home message of this third case is that epiploic appendagitis is a rare cause of abdominal pain in adults. For the management, it's medical, unlike appendicitis. That's why it's important to perform the CT scan, because it will give you the correct diagnosis and it will avoid that the patient go into an unnecessary surgery. Because if you tell him that it's an appendicitis, he will go into surgery and they will open and they can't do nothing. They will just open it and close it again. So please be careful and please think of this diagnosis. So the management of the patient that we had was the patient was treated medically with anti-inflammatories and analgesics for 5 days, and he was good. And of course, the take-home message that I think I will repeat in every presentation. Every image tells us a patient's story. The precision in analysis can save life, and I hope that you carry forward this curiosity into your practice and always think of the unthinkable. As we conclude, I want to extend my heartfelt gratitude to the two remarkable mentors who have greatly enriched this presentation with their wisdom and expertise. I always make sure to show them this first before presenting it to you guys and girls. Oh. So this is the first mentor. She's a pillar of knowledge and inspiration, and she's more focused on breast imaging and breast interventional radiology. And the second one is Dr. Asma Husseini. Her expertise and dedication in radiology is so good. She's a skilled radiology specialist with a focus on traumatology and neurology. And our final quotes While mentors light the path, it's your steps that create the journey. Believe in your street. So as we conclude, I hope that you can give me your feedback after finishing this presentation. I will really appreciate it. It will not take you a lot of time, just 2 minutes. And I can see, and after seeing it, I can make better presentations for you.